Well, good morning, everyone, and welcome. My name is Amit Garg, and it's a privilege to have everyone here today for our first annual conference for the HDRN Canada Pragmatic Trials Training Program. Uh, I'm I'm dialing in from London, Ontario, where the coordinating center operates out of. This conference is really exciting because we have a real challenge in healthcare currently. Certainly we'd like to explain and predict what's happening, but our biggest effect in terms of research is when we can intervene, when we can change the natural history, either of our patient or a healthcare system. And unfortunately, over 75% of the interventions we currently use in healthcare and policy are not supported by high quality evidence, which comes from large randomized controlled trials. And any of us involved in trials know how challenging they are to do. They're difficult to fund, difficult to conduct. They often don't execute as planned. They often don't meet their recruitment target. And then you often don't get an adequate answer to the question. And so you're left with an unreliable estimate of the treatment effect, and we don't really advance medicine and science. So just like a 2 a.m. info commercial, there's got to be a better way. And the better way is for some types of questions. This is not appropriate for all types of questions, but for all types of questions, where they can be delivered in routine healthcare by clinical staff rather than research coordinators, where we can leverage existing data sources like those available through HDRN Canada. Can we do trials in a better, faster, more streamlined and efficient way at a fraction of the cost so that we can truly practice evidence-based medicine? Because right now, that's not a reality given the tremendous cost of trials. And so one of the key aspects of this training program is a virtual conference, and this is our first annual conference. We're so grateful for all the learners in our program, over 75 learners, the faculty who supports the program, and I'm very indebted to all the excellent people at the coordinating center. And so to start us off, I'd like to introduce Joe Singh, who will be moderating today's session. Dr. Singh is a research scientist at the Saskatchewan Health Authority and a highly qualified personnel in the Pragmatic Trials Training Program itself. He has extensive experience conducting clinical trials and has been involved in many international registries focused on cardiac disease, so we're very privileged to have him moderating the session today.
Perfect. Thanks very much, Amit, and welcome everyone. It's great to see such a big attendance here, and I hope everyone has a great time at the conference as well. So I'd like to start today with a land acknowledgement. We acknowledge that the Pragmatic Trials Training Programs Coordinating Team's offices, which are located in London, Ontario, are on the traditional territories of the Anishinabek, the Haudenosaunee, the Lenapehoik, and the Adon-Wandaron. And this land continues to be home to diverse Indigenous peoples, including First Nations, Métis, and Inuit, whom we recognize as contemporary stewards of the land and vital contributors of our society. We also recognize that our work is carried out on the traditional territories of First Nation, Inuit, and Métis people from coast to coast, and we are thankful that we are able to work and contribute and collaborate and contribute on these lands. Perfect. So as far as today's or this morning's conference goes, it's going to run from 11:15 to 12:15 Eastern Standard Time. And a quick lunch break will follow 12:15 to 12:55, followed by our afternoon presentations from 1 to 2 p.m., again on the Eastern Standard Time. The agendas, speaker bios, and session links can all be found on the left-hand side of your feed loop menu. And from here, just a reminder as well that the conference will be recorded and a copy will be sent to all attendees. Each session will begin with a presentation by one of our trial leaders, and this will be followed by a panel discussion and then concluded with our audience Q&A. If you have housekeeping questions throughout the day, please add them to the session Zoom chat. You can also privately message another attendee by navigating to the networking tab on the left-hand menu. And then the lobby chat will also, the lobby chat will not be monitored. So please make sure you use this session Zoom chat if you have any of those housekeeping kind of questions. During the audience Q&A, please feel free to raise your hand you can hop off mute as well. And you can add your questions to the chat as well if you'd like, and we could try to get through as much as we can. And any questions we don't get to during the Q&A, we can send those to the presenter as well. So we also welcome your feedback on the presenter's protocol, and any feedback added to the chat will be passed along to the presenter, or we can also email it to pragmatic.training@uwo.ca. Perfect. So we'll keep going here. Awesome. So now time to get to the fun stuff. We'll get started with our first presentation, and it's my absolute pleasure to introduce our first presenter, Dr. Abhijat Kichlu, who is an expert in onconephrology. Today, they will be presenting on improving cancer screening in kidney transplant recipients. And then following the presentation, we'll have a panel discussion featuring Manuela de Paula Ferrere, Dr. Allison Allen, and Dr. Monica Zizanowski as well. Awesome. So please join me in welcoming Abby. And Abby, I'm going to pass, you should be able to share your screen, right?
Yes, I hope you may be able to see my screen now.
Perfect.
So thanks very much for the kind introduction, and my thanks also for the opportunity to present our proposed pragmatic clinical trial, which aims to increase cancer screening in kidney transplant recipients. Our trial is still early in its development, and perhaps one of the indications of this is that it has yet to get a catchy trial acronym as of yet, but I hope given its early initial stages, it will particularly benefit from our panelists' input as well as the input of the audience. And again, appreciate the HDRN Pragmatic Clinical Trials Program for providing this opportunity for discussion. So thank you again. Our proposed research question in general terms asks, in adult kidney transplant recipients in Ontario, does a transplant program-based cancer screening strategy, which would include electronic health record-based reminders to patients, with or without nurse navigator outreach, increase the uptake of guideline-recommended, age-appropriate cancer screening procedures? We are still considering which screening procedure outcomes on which to focus, but the potential list includes colorectal cancer screening via fecal immunochemical testing or colonoscopy, and breast cancer screening via mammography, which are bolded here, although our outcomes may also include additional recommended screening procedures noted at the bottom of the slide here. So why is this type of initiative important? By way of background, there are 3 key points I would like to impress on you. First, kidney transplant recipients are at significantly increased risk for cancers, including those for which we have screening procedures. Also, transplant recipients with cancer have worse outcomes than the general population. Secondly, cancer screening uptake has been shown to be suboptimal in transplant recipients, and this is the case despite existing cancer screening programs in Ontario. And third, patients and clinicians may recognize the importance of cancer screening, but face barriers to implementing this. I'll not belabor the underlying mechanisms for increased cancer risk in transplant recipients, but briefly, these may include issues related to immunosuppression for transplant receipt, specifically exposure and susceptibility to viruses associated with the development of cancer, inability to respond to DNA damage. Next, some requisite induction and maintenance immune suppressing medications used in these patients, like calcineurin inhibitor drugs and T-cell depleting therapies that may increase the risk of certain tumors. Female patients may be at elevated risk compared to the age-matched population as well. And I'll just mention also that there are certain immunosuppressive medications that may have anti-tumor effects, and early detection of cancers might prompt a change in immunosuppression for some patients. As a result of these factors, we have data to show that the overall incidence of cancers in transplant recipients is about 2 to 3 times that of the general population, and about 10 to 15% of these patients will develop solid cancers. The figure on the right shows standardized incidence ratios for a number of cancer types. Although the highest relative incidence is with cancers associated with viral infections, like lymphomas and Kaposi sarcoma, cancers for which we have screening strategies certainly also have increased incidence. It's not only the incidence of cancer that's concerning, but also cancer mortality, which is about 2-fold higher than the general population. Cancers are the second leading cause of death in kidney transplant recipients, and cancers with screening procedures do have substantially increased mortality rates in this population. This is data from a large Australian registry study, and I'll highlight also that cancers in this population have been confirmed to develop post-transplant rather than previous malignancies that have recurred. I'll also mention that these cancers may occur early in the first few years post-transplant, and so screening should not be delayed despite all the other healthcare considerations that these patients may have in the post-transplant period. I'll lastly just point out that this concern has been specifically shown in the Canadian context using Ontario Healthcare Administrative data. We observed that Ontario kidney transplant recipients have a total cancer incidence of about 25% above patients with normal kidney function and about 50% increased cancer mortality. Patients with kidney transplants also had a higher proportion diagnosed with more advanced or stage 4 cancers, with about 25% of patients with stage 4 cancer at diagnosis, compared to about 20% in the general population. So with these concerns about increased cancer incidence, more advanced cancers at diagnosis, and worse cancer mortality, how are we doing with respect to completing cancer screening in Ontario for this population? This is a 2017 study by Wong et al. Looking at the breast cancer screening rates in women across levels of kidney function in Ontario. The leftmost or light gray bar represents normal kidney function, and the rightmost or darkest gray bar in each age category represents kidney transplant recipients. Here we see that the rates of screening uptake are around 55 to 67% in the general population, but only about 48 to 56% in kidney transplant recipients. And overall, kidney transplant recipients have about a 20% lower likelihood of undergoing mammography compared to the general population. When we look at cervical cancer screening rates in Ontario, screening uptake is even further reduced. Again, the lightest gray bars represent the general population, whereas the darkest gray are transplant recipients. Here, in every applicable age category, kidney transplant recipients have lower screening rates. Overall, kidney transplant patients had about 35% lowered hazard of completing cervical cancer screening. Lastly, our Ontario data on colorectal cancer screening is a little bit older and also includes solid organ transplant recipients, not just kidney transplant recipients, but it shows us a similar story with significantly reduced rates of colorectal cancer screening in these groups of patients. This is from the same study by Acuna et al. And here I would highlight that screening uptake was largely similar across the solid organ transplant centers in Ontario. Although if patients had seen their primary care provider in the previous year, they did have a higher likelihood of being up to date with cancer screening. I've shown some of the Ontario screening guidelines for common cancers, including colorectal, breast, and cervical cancers. There's unfortunately very limited data showing the specific benefits and risks of screening in the kidney transplant population, and as such, most screening recommendations are extrapolated from the general population to kidney transplant recipients. The one exception is colorectal cancer screening, where the fecal immunochemical test, or FIT, has been demonstrated to have good performance characteristics and similar to the general population. I won't go through all additional potential cancer screening procedures, but it's worth mentioning that there is no Ontario screening recommendation for liver cancers, though some sources for recommendations for transplant recipients suggest consideration of this in patients with cirrhosis. Prostate cancer screening on a population level is not currently recommended, and lung cancer screening is suggested for those with 20-pack year or greater smoking history. Our recent global survey assessed barriers to cancer screening perceived by clinicians. Issues of financial costs of screening were significant globally, but may be less directly applicable in our healthcare context. But other issues, including lack of awareness of cancer screening, lack of time to discuss this during patient visits, and lack of comfortability with screening discussions, may all be barriers to the completion of screening in this population. So to recap thus far, kidney transplant recipients are at increased cancer risk, have worse cancer outcomes, and have a reduced uptake of cancer screening. With these issues in mind, the primary objective of our trial would be to determine whether a transplant program-based cancer screening strategy using electronic health record-based reminders with or without nurse navigator outreach increases the uptake of recommended cancer screening procedures compared to usual care. Secondary objectives would include determining whether such programs would result in increased cancer diagnoses of all cancer types and the screen malignancies, earlier median cancer stage at diagnosis, increased false positive cancer screening tests, increased patient-reported satisfaction and well-being with the screening interventions. To achieve these aims, we have suggested a pragmatic randomized control trial. Some of the major aspects that may lend this type of study to a pragmatic trial design include the fact that cancer screening procedures are currently part of recommended usual care and are well captured in currently collected healthcare administrative data in Ontario. In addition, cancer diagnoses and stage at diagnosis would be available using the Ontario Cancer Registry. We have been considering patient-level randomization as opposed to cluster or center-level randomization, and we would also consider the use of randomization based on OHIP numbers, as this has been used previously in other pragmatic trials involving patients with kidney disease. There may also be specific consideration of randomization strata based on the age and sex criteria for eligibility for certain cancer screening tests. Lastly, I'll mention here that cancer screening is already recommended as part of usual care and that our intervention is primarily reminders and outreach to increase this. There may be consideration of waiver of individual patient-level consent for participation. With respect to study population, we would like to include adult, prevalent, and incident kidney transplant recipients who receive follow-up care in transplant programs in Ontario. You'll note we haven't specified an age threshold yet, as the specific cancer screening procedures included in the intervention and outcomes will help determine this. We have suggested including 4 kidney transplant programs in Ontario that use the same electronic health record. This is relevant as this EHR, called EPIC, involves a patient communication portal. Patients at present already routinely receive email or text messages regarding their upcoming appointments, lab tests, or imaging procedures. This patient portal could be used to send patients a reminder regarding cancer screening procedures. We have suggested that we would include patients more than 1 year from the date of kidney transplant, as in the first year post-transplant, patients may have a number of active issues directly related to their transplant care. We have also suggested inclusion of patients who are still directly followed by the transplant programs rather than only by their primary care providers. Potential exclusions may include those residing outside Ontario, those with kidney graft failure, in other words, those receiving dialysis, patients who have opted out of electronic health record communications, and those receiving active therapy or surveillance for a previous cancer diagnosis. Regarding the intervention, as mentioned, this is still at the development stage, but we have proposed a tailored electronic reminder sent through the patient-facing portal. This reminder would highlight that patients post-transplant are at elevated cancer risk and that screening is recommended by their transplant clinicians. Previous studies have suggested that these tailored reminders, including mention of the patient's specific care teams, may be more likely to result in screening uptake. We would also seek guidance from experts in cancer screening interventions and patient partners to guide the content of the reminder. The route of notification, i.e. email or SMS with a link to the patient portal, would be the same as other notifications received through the patient portal. I'll mention again that patients currently use this for information about clinic visits, checking in and completing registration or questionnaires in advance of appointments, and even reviewing their clinic notes and test results. In addition to this electronic health record reminder, we are also considering an additional intervention arm that would include either a phone call or a virtual visit with a nurse practitioner. For example, at the University Health Network, there exists a program called Connected Care, which provided telemedicine consultation with nurse practitioners for COVID-19 infections, post-hospital discharge care, and other issues. We are exploring whether this could be leveraged for visits in which patients' cancer screening history is reviewed and potentially ordered directly. The comparison group in our study would receive usual care for cancer screening. It should be mentioned that currently, kidney transplant programs in Ontario do not directly order or monitor cancer screening on a program-wide basis. Some clinicians may incorporate questions about cancer screening or encourage screening, but this is not done in a systematic or formalized way. Some patients may have screening arranged mainly at the discretion of their primary care providers. I should mention, though, that patients would still be expected to receive physical mail reminders for breast, cervical, and colorectal cancer screening as part of Cancer Care Ontario's provincial screening programs for the general population. As mentioned earlier, despite transplant recipients currently receiving these general population reminders, uptake has been suboptimal. Regarding outcomes, the primary endpoints would be the proportion of patients who complete screening tests in the two intervention and control arms. I've indicated here that at present we are considering focusing on the FIT for colorectal screening and mammography for breast cancer screening, as patients could complete these tests directly, either ranged through the hospital or through the Ontario provincial screening programs. They would not require another referral to an additional provider, say a gastroenterologist for colonoscopy, or provider who may perform Pap testing. As secondary outcomes, we would look at overall and site-specific rates of cancer diagnoses, as well as median cancer stage at diagnosis. These two outcomes would be obtained in healthcare administrative data. We would also, however, like to assess the rates of positive screening tests that did not lead to a cancer diagnosis, and also assess patient response to the intervention arms, particularly if they found the reminders and outreach intrusive versus potentially increasing the satisfaction with their care. This, however, may require some additional prospective data collection. Regarding sample size, as mentioned earlier, many cancer screening procedures currently have uptake rates in the range of around 50%. To increase this uptake rate to around 60% in the intervention arms, assuming 80% power and two-sided significance of 0.05, we would expect to require around 776 patients. This represents about 14% of Ontario's approximate 5,600 kidney transplant recipients. As to our current status, at present, clearly the trial is early in its development phase, and we have yet to finalize the intervention arms and the screening procedures outcomes included. But we have, however, sought input from kidney transplant colleagues at the University Health Network who have shown initial interest, as well as some colleagues at other sites. We've also had some initial discussion with experts in cancer screening studies, including Dr. Jill Tinmouth, who has been involved in the Ontario Colorectal Cancer Screening Program. There are, however, several challenges ahead of us. These include confirming the intervention strategies and ensuring that the electronic health record-based reminders can be feasibly sent through patient portals. We also need to determine whether the outreach and nurse navigator arm would have available personnel and funding resources to support it. Importantly, we also need to ensure that if abnormal screening results are obtained, that the kidney transplant programs may be agreeable to receiving notification regarding the results of screening, or even considering ordered screening procedures when patients may not be able to facilitate this through their primary care provider, particularly if they may not have a primary care provider. Lastly, we do need to explore whether the trial intervention would be appropriate for waiver of individual level patient consent. With that, I'll close and look forward to discussion with our panelists. I would just like to thank my mentors and collaborators listed here, including those involved in the HDRN Pragmatic Trials Training Program. Thanks very much for the support and the kind attention. Thank you.
Perfect. So thank you very much, Abby. That was awesome and exciting to hear about as well. We'll transition to our discussion now. So we'll begin with questions from the panelists, and then we'll open the floor to the audience for questions. And Abby, if you could stop sharing your screen, I'll go ahead and share mine as well and just put a picture of the panelists up there. Perfect. There we go. So to the panelists, if you could briefly introduce yourselves before your first question, that would be great, and we will go from there.
Hello, everyone. I don't know who should be the first one.
You can go ahead, Manuela. That'd be great. Yeah.
Okay, so very nice to meet you, everyone. Thanks, Abby, for your great presentation. My name is Manuela. I am a CDTRP Research Services Manager. A little bit about my background. I am a physical therapist, and I have a PhD in Parkinson's disease and home-based dance exercise program. But my postdoc was related to solid organ transplantation, and I worked in the General Hospital with Dr. Sunita Mathur and Leanne Singer. And that was kind of my connection with solid organ transplantation. So yeah, I am not a physician, but physical therapist. So I relate to patients when it comes to long-term outcome. And thanks for bringing your topic to our discussion today, Abby, again.
Thanks very much, Manuela. I appreciate your attention and input.
Thank you. So should I jump with one question, or we go to Monica and Alison?
We'll go with your question first, Manuela, and then we'll pass it on to the other panelists and go through the process again.
Okay, thank you. So my first question would be related to how often will the cancer screening reminders be sent out to the intervention groups? And for how long are you planning to follow up with your participants to measure all the outcomes that you have described in your presentation?
Well, thanks for raising that important point, Manuela. And I think this aspect was perhaps glossed over a little bit because of the lack of sort of confirmation with respect to the exact intervention and outcomes. And I think the frequency of screening reminders would depend a little bit on the types of interventions included. One thought that did come up in our discussions in our protocol development meetings would it be reasonable to send an annual reminder related to multiple screening procedures to patients and not necessarily be dependent on existing data confirmation of which recent screening procedures they have been completed. In other words, make it a blanket reminder, say at some point, perhaps on the anniversary of their transplant, to indicate that these issues are important for follow-up and provide some awareness and recommendation to patients to seek their primary care provider or the transplant program to complete these screenings. I think there is a potential to use this on an annual basis for more general aspects related to preventive care, primary care for patients. But if we were to choose to only focus on specific cancer screening outcomes, we may do this just on the frequency of the recommendation from Cancer Care Ontario with respect to screening. So for example, in mammography, it may be every 2 years for patients. So this is still a little bit to be confirmed, but somewhere between annually and the frequency recommended for the particular cancer screening procedure. Thank you.
Thank you.
I'm happy to go next. Monica Krasnowska, I'm a medical oncologist at Sunnybrook and the program chief for the Odette Cancer Center and health services researcher by background. And so Abby, great presentation. I was very excited to be sent your proposal, and this is a very an excellent idea, and you presented a very strong rationale of why this is important and that there's an existing gap. So one question I had, which had related to maybe understanding a little bit more about the implementation barriers. You had briefly mentioned that you had done an international survey of providers to look at why cancer screening rates may not be adequate in this particular patient population. Do you have any information on more specifically within Ontario, so within our context, about which are some of the key barriers? And why I ask this is just trying to make sure that the interventions match the barriers for patients. And then also, have you considered any kind of, or is there any research with patients, and what are their barriers to getting cancer screening within this context?
So thanks very much for the great question, Monica, and I appreciate your time and experience in looking at this type of proposal. I should clarify that the global survey, in fact, was led by one of our nephrology colleagues in Australia, Jermaine Wong, who's collaborated with our group in the past and some work related to this area. Their group looked with the survey I presented primarily with clinicians, but have also done some qualitative work focusing on colorectal cancer screening in patients. And some of the issues, I think, are concerns that a reminder or awareness-based intervention would be valuable for particularly including issues related to patients maybe a lack of awareness or lack of specific concern for cancer-related issues, given a previous focus on kidney health-related issues in these kidney transplant recipients. So this qualitative work has nicely produced some quotes from patients related to concerns such that they have, enough to worry about, so to speak, dealing with their kidney health and their transplant without, quote unquote, looking for trouble related to other concerns. But I think this may result in important issues being left by the wayside, and it may be incumbent on our programs to help present this to patients in an accessible way and facilitate a faster approach to screening for some of them. So these concerns related to awareness have been highlighted in the past. I think the concerns related to other issues to worry about pushing cancer screening lower on the priority list also potentially would benefit from this type of intervention to kind of raise it amongst the issues that patients may bear in mind in their post-transplant care. Other concerns are barriers maybe that this type of intervention would understandably not be able to assist with, like patients who may not have routine access to a primary care provider, which is increasingly a concern in Ontario. It may be difficult in some ways for patients to find opportunities to bring up concerns with respect to cancer screening. And this is why I thought the quote related to inability for time to discuss cancer screening in that global survey was maybe particularly applicable to our healthcare context as well. For this reason, if we were to have the opportunity for a follow-up virtual visits or a nurse practitioner-based outreach program to focus on the cancer screening issue, maybe this would allow for some facilitation of cancer screening independent of the rest of post-transplant care. Also, if there was opportunity to order this directly through the transplant programs, as in focusing on interventions which could be done through either hospital-based resources or the Ontario Provincial Cancer Screening Programs, this would put less onus on primary care providers to complete this testing. So I do think there's room for more work related to some of the specific barriers that patients face, but I hope, based on what we know so far, this intervention may help surmount some of these concerns.
Thanks. Maybe I'll turn over to Allison for the next question.
Great. Thank you very much for the presentation. Some of my questions actually, so it seems like the trial design has evolved since we got a copy of the protocol. So some of my questions actually have been answered by that evolution. So that's great to see. But my question is a little bit on trial design, but actually dovetails nicely with the last discussion that Monica initiated. And that's really, so the first is sort of, I guess sorry, Joe, I'm supposed to introduce myself. So I'm currently the Associate Vice President for Research at Western University, overseeing the health portfolio. And I'm also a translational cancer researcher where I work very closely with radiation oncologists and medical oncologists to do correlative biomarker analysis in phase 1, 2, 3 clinical trials. So my question is really around the nurse navigator intervention. So it kind of aligns really nicely with the discussion that you had with Monica. And so just for my own knowledge, do the kidney transplant teams in Ontario, do they have a nurse navigator or nurse navigators as part of their care teams? Or is this something that you would have to add to the clinical setting?
So another very important question, Allison. I'd say most programs in Ontario don't have sort of a specific allocation of a nurse navigator within the program. Many of them do have transplant care coordinators who often have nurse practitioner training, but are quite clinically busy with other post-transplant related issues. For this reason, particularly at settings where there is another approach to virtual care. More recently at our center, the University Health Network, there's been a separate team directed towards so-called virtual care or connected care for patients. And this was quite active, of course, during the pandemic, and even provided administration of antiviral therapy during the pandemic, and is now focusing on providing things like post-discharge care and surgical transition care. So my hope is that a team like this could be leveraged. Now, it's not the case that every transplant program may have access to this. And so for this reason, we were wondering, would this type of intervention maybe need to be restricted to sites that offer this type of resource? And, would there be a need for a pilot phase maybe to demonstrate the benefit of this type of intervention on a smaller scale first? So those are some considerations at present. I do think that overall still the EHR-based reminder may still have particular benefit even in the absence of the virtual visit or nurse navigator provider. But to maybe point to some of the concerns that Monica raised earlier, there are some barriers that patients may face that really the additional outreach would really hopefully help surmount, whereas the electronic health record reminder may focus on some of the barriers related to awareness and lack of priority. So it's going to be necessary to kind of tease out to what degree we can provide additional intervention to surmount some of these concerns that are not awareness or priority based alone.
Yeah, I think, I think the data on the nurse navigators probably wouldn't be surprising as an intervention, but I wondered, just on a related question before I pass it back to my fellow panelists, in the data analysis plan, is there any consideration around having, patients with or without a primary care provider as sort of a stratifying factor in the analysis? I don't know if that's something that you can reliably pull from the ICES data, but it, in the theme of finding ways of supporting these patients, or what might the barriers be, I wonder if is that a factor that could be taken into account?
So I think that's a great idea. We hadn't specifically commented on in the analysis plans, like stratifying for the availability of a primary care provider. Some of the data I had shown from a prior study from Acuna et al. Showed that patients who had been regularly visiting their primary care provider were more likely to have available cancer screening. And so, I do think it would be a great idea to try and maybe make a comparison, not only on the screening uptake, but the patient-reported outcomes and the satisfaction with care that patients who don't have a primary care provider have with the addition of this type of intervention. So that's a great thought. Thank you.
Perfect. So before we move on to our audience questions, I just wanted to ask again if the panelists had any additional questions for Abby.
I do have one quick question, and this is still related to the patients. So I know your study is not looking for cancer prevention, but detection, but still, how much information do patients have about the measurements of cancer prevention and how to prevent it from developing after kidney transplantation? And I know one of your secondary objectives is to measure patients' satisfaction over the reminders. Would you consider also looking to the patient's knowledge regarding cancer after transplantation? Because maybe that will also help them on engaging with the cancer screeners.
That's a great thought as well, Manuela. We have seen some prior work related to some of these qualitative surveys, particularly in the colorectal cancer space, that have been done by some of our prior colleagues related to how they prioritize cancer screening in relation to other healthcare concerns. But to my knowledge, there has not been a lot of work to show specific awareness, particularly related to preventive issues. I know that the the Cancer Care Ontario website has some information related to, if I'm not mistaken, like My Cancer IQ, where patients can provide some of their personal history, including family history, habits, demographic data, and have it comment on cancer risk. And one thought is, can we incorporate some of this in addition to our information about completing cancer screening? I do think we would have to be careful and seek patient input as to how much information is enough to achieve the aim of increased cancer screening without overwhelming patients with information that may be worrisome or perceived as intrusive. So we want to strike that balance. So I think involving our patients to try and help find that ideal balance between enough but not too much information would be optimal in trying to define the intervention.
Perfect. Thank you very much.
Abby, I had a couple more questions and maybe like comments. You had mentioned, one of the things I think you mentioned in response to one of the other questions was around pilot work, right? This is a very, complex intervention in terms of, building out an IT alert, the content, the frequency, and then if you had an intervention in terms of facilitating the screening, what happens if there's abnormal things. What kind of pilot work are you thinking about in terms of, I'm not sure that you need to do a pilot randomized study or maybe, but at least some sort of pilot work. What are you thinking about?
So what we had envisioned initially is to see how easily patients would respond to a notification in their portal. And I will say, there has been quite a lot of uptake of use of the patient portal at sites locally, at least, in that patients will complete their pre-registration information, including even providing things like their current medication list and screening for viral symptoms before a visit. So I think there is some good utilization of this more broadly amongst users of the patient portal. But I think some initial work would have to show us that, if they received a notification like a cancer screening reminder, that they would in fact click on the link and make use of this. I think also, the pilot work would have to involve sort of some look at the ease of use of a notification in the portal. And so having some initial patients trial receiving a notification and being able to sort of work through receipt of this and whether the information within the notification is sufficient to let them seek out input from their transplant program or their primary care provider. So we haven't sort of determined should this be involved in a randomized pilot phase, or can we have this done upfront without reaching the point of randomization? My feeling is probably there needs to be some pre-trial work that really shows the use. As you pointed out, it is a more complex intervention, and input from clinicians as well as patients initially would probably be necessary before we got to the randomization phase.
I do think I would strongly encourage that, because I think these are many complex workflows, and so trying to get some input from the teams, all the different stakeholder groups. You may also wish to consider speaking with some primary care physicians, because if this has been within their realm and now you're going to be potentially, especially if you have a nurse navigator, kind of interfering with the regular pathway, there could be downstream effects in terms of, whose responsibility it is, and that can either result in patients not having the right screening because no one knows who's in charge, or patients having duplicate screening. So, so that's one of the other things to think about in terms of measuring. And then the only other question I had for you, and maybe just to make sure that everyone else has an opportunity to ask, is in terms of your outcome measurement. So I do think that using the ICS data would be a good use for using it like publicly available, like the provincial data, and you'd be able to tell who's had a kidney transplant and who's had the screening of interest. But like, what are you thinking in terms of procedures of like actually identifying which patients were randomized to which kind of intervention? Because that for that you need to have you need to know that at the patient level. Have you thought through that?
So just in initial terms, what we had envisioned was the transplant programs would hopefully provide ICS with information as to transplant recipients who are followed in the program. And of course, ICS data could also be used to identify this as a proportion of overall transplant recipients, and also patients who have consented to contact through the patient portal. So these would be patients who are at first line sort of eligible for the randomization. And then the randomization, if using, for example, OHIP numbers to generate the randomization, could happen at ICS, and then the intervention would be sort of rolled out based on who has been randomized to each of the arms. And I do think the follow-up of outcomes should be possible to be done through ICS data thereafter. As I mentioned, there probably would be need for some information on who's randomized to each arm for prospective data collection related to satisfaction and patient-reported outcomes following use of the intervention, whether it's electronic health record reminders or the nurse navigator. So this is sort of some of the initial thoughts we've had so far as to how the randomization may proceed logistically. Welcome any other input or suggestion in that regard.
And the only thing, so I think the if you're going to get actual OHIP numbers for patients who are enrolled in the study, I do wonder if you're going to need actually that individual patient consent. We had done a study where we used ICS-based data to look at our outcome, and for any components that we had like actual linkage of data to the ICS holdings, we did need to get consent, even though some of the intervention was like a quality improvement kind of intervention. So not every patient, like if we didn't need to link them, didn't need the consent, but if we needed to get OHIP numbers and link, then you needed consent. So that just, you might need to think through that in terms of the ethics approval and the sort of logistical procedures for linking the data. So, and I'm happy to chat with you separately about what we learned from that whole experience of linking back to the admin data.
Thank you. I'd very much appreciate that, because this would be an important consideration as to how we approach the consent piece. So I would value your input for sure.
So, I mean, I had a question that's maybe a broader clinical impact question. So I was interested to see the data that you presented in terms of the types of cancer that were impacting the kidney transplant patients, and the I guess screenable cancers within the current Ontario screening program were actually lower on the list. And so from a pragmatic clinical trial perspective, obviously see the logic in focusing on, I think breast and colon is the right place to start. But I wonder if, in terms of, so say this is a successful trial, are there thoughts about how you could maybe address those the more common cancers in the kidney transplant recipient? I don't know if that's something that your colleagues in the field have thought about as well. And the challenge, I guess, is there's not standardized screening right now, and it would involve a much more complex, I guess, clinical intervention to do that screening. But just wondered what kind of thoughts and conversations you'd had around those things.
Thank you for raising that point. And when conceptualizing this, I did have this concern that are we putting our focus in the wrong place in terms of what will benefit patients most from a cancer outcome perspective. But again, in view of the pragmatic nature of the trial, we did want to focus where there is currently recommended screening procedures that are guideline suggested. I would say my hope is that if such a trial were to be successful initially, that this would increase the overall involvement of transplant programs in the concerns related to cancer in these patients. And so even though there may not be sort of widely agreed upon screening programs, there may be issues that are taken more ownership of in the transplant programs. I mean, some areas that we see a lot of this already is things related to post-transplant lymphoproliferative disorders and screening related to EBV serology. And so formalizing that as part of sort of the process of care, I think may be beneficial and may be one of the secondary effects of a trial like this, and that I think a lot of transplant programs are very comfortable with reducing things like cardiovascular risk for patients. There may be less so sort of a focus on cancer outcomes, understandably now, but this might be an opportunity to have this be brought to the fore for transplant recipients. But we would need some additional work to look at, what is the right way to incorporate what procedures don't yet have a standardized approach to cancer screening. So that would, I hope, be something that could be looked at secondarily after hopefully a trial like this is initially successful.
Great, thank you.
Perfect. So thanks, panelists. And now we'll go ahead and move on to our audience. If anybody from the audience, if you have a question, please use the chat function, or you can raise your hand. And I can call you out, and then you can come off on mute, and we can go from there. So Eric, I see your hand is up. You can go ahead.
Thanks. Can you hear me okay?
Yep.
Yeah, okay, thanks. Yeah, I just thought I'd speak up because my question was sort of related to Allison's excellent question. And thanks, Abby. Thanks for presenting your protocol and the excellent presentation. I'm a medical oncologist in London as well. So basically, you showed data that, there's a very high prevalence of, or incidence rather, of skin cancers in this population. And I was wondering what the standard process is right now. Is there, and the biology of these cancers is often much more aggressive and often lethal. So I was just wondering, what is the current status of screening for skin cancers in transplant recipients? Is it done routinely? Is there data about whether it is effective or not? And if so, is it something you could potentially incorporate in your trial design?
So thanks very much for this great question, Eric. There are some recommendations from guideline bodies regarding skin cancer screening. This is a major concern in the post-transplant population. And this is from sort of my recollection itself, as opposed to something in front of me at the moment. But I believe the recommendation suggests that patients should be doing a monthly self-skin exam, and every 6 to 12 monthly should have an exam with what's in the guidelines, a trained clinician, which could include a transplant care provider, dermatologist, or primary care provider to complete skin examination. So this is something that we did wonder about. So I'll mention, apart from what I had shown in the PowerPoint, the other cancer screening considerations we thought about were issues related to post-transplant lymphoproliferative disorder, skin cancer screening, and we also thought about lung cancer screening and renal cancer screening, as all of these have been considered in the post-transplant population. I do think it may be important to consider awareness and recommendations around skin cancer screening in particular to patients, and could potentially be included as part of the intervention. Our concern was that it may be more difficult to look at the uptake of skin cancer screening examinations. I suppose in healthcare administrative data, we might be able to look at primary care visits or visits with a dermatologist potentially as well. But other skin examination may be more challenging to ascertain using healthcare administrative data. Doesn't mean we shouldn't consider it as an additional outcome to look at, but at this stage in the development, we hadn't yet place that on the list of outcomes to look at through ICS data as of yet, but would welcome thoughts or suggestions as to how to include this potentially.
Thank you.
Perfect. Thanks, Eric. And Gordon, I see your hand is up. You can go ahead.
Hi, thanks very much for that great talk. Really enjoyed listening to your protocol. I'm Gordon Fernie. I'm at the Ottawa Health Research Institute. One of the things that just occurred to me as you were talking about your message was whether or not within the electronic health record you will know if the patients read your message, if that's something that Epic provides already. And if it does, that's fantastic. If it doesn't, then is there a means in which you can embed some sort of link that would allow you to get some sort of click through or view as to, with further information to educate the patients and give you some sort of indication that your message is actually being processed and acknowledged by the patient?
Thanks, Gordon. That's a great thought to include an option to confirm through a patient action like a click response to ensure that they've received information. We haven't yet had the opportunity to go through our colleagues on the IT side in Epic to ensure that there's a mode to confirm use of the notification. I know that for laboratory testing, for example, there's a confirmation in Epic as to whether a patient has viewed a result, but I don't know if this can be applied in the same way, but my feeling it is possible to confirm that a patient has at least clicked on a link within the portal. It may be better still to have a response from them to say, I've received this notification, and even potentially as a way to have them interact with their cancer screening risks. The idea of, can we provide some information to patients on their individual cancer prevention concerns? This has been suggested through like questionnaire approaches as well. So it may be possible that we could build this into the EHR notification, but this is still to be explored as of yet.
Thank you.
Perfect. Thanks, Gordon. And I don't see any comments on the chat. Does anybody else have any questions? Please feel free to raise your hand. Michael, I see your hand is up as well.
Hi, great presentation. I'm sorry if I'm going to ask you, if my question will result in repeating anything you've already said, but I'm just wondering whether, to what extent you'll do some perhaps qualitative work alongside the trial with patients. And I guess what I'm specifically thinking about is the potential for confusion amongst patients with respect to perhaps multiple requests or invitations they're getting for screening, things that come through Ontario Health, things that come through their primary care provider or otherwise, and then as a result of the trial. And whether this is a concern for patients or not. Is that something that you're going to be able to look at as part of the trial, just to really understand how to do this in a way that's most helpful to patients in terms of navigating the system?
So thanks for raising that, Michael. I have to say, this is not something that we previously addressed fully in our discussion so far. I would say absolutely it would be great to look through some qualitative means regarding patient satisfaction with the interaction, and particularly avoidance of confusion regarding multiple sources of messaging. I think one thing we did point out is upfront it would be important to have patient input as to the information provided in the reminder, and the source of it being the transplant program itself. And I do think there is some benefit, as previous screening interventions have suggested, that patients who receive a notification from someone who is part of their care team, or even a notification that is indicative that it's in agreement from their primary care provider or others who they trust directly is more likely to achieve an increase in screening. And so having some of that upfront input would be beneficial, but I do think as additional outcomes to explore qualitatively, it would be helpful to look at avoiding confusion with these multiple notifications potentially. As mentioned, there does probably need to be a sweet spot in terms of not overloading patients with additional concerns, but still providing them enough information so that they can appropriately prioritize an issue like cancer screening.
Perfect. Thanks, Michael. Sabrina, I see your hand is up as well. You can go ahead.
Hi, thank you for this really very interesting presentation. And I was wondering, when you're talking about cancer screening and randomizing through at the patient level, I had in mind initially when I was listening to the objectives that this would maybe be through the physician level, that the physician would get the notification, and then, and as you said, if the message comes directly from the physician, then maybe it makes more sense to the patient. But then I also thought if it goes through the physician, then there might be some contamination. Like if it was a patient level, but the physician was giving it to the patient, there could be contamination within this this cluster. So I was wondering if that was a thought when you were in the thought process of how you decided to go with patient randomization. So I was just curious if this was part of why you had chosen this design.
Thank you for the question. We did have some considerations as to what the best approach would be for randomization. Because of the relatively smaller number of transplant programs and transplant conditions, we had lent towards patient randomization initially. One other consideration is to what extent have provider-facing notifications been helpful, and I do think there's some data looking at notifications to providers regarding patients being out of date with respect to screening or being due for screening. But these, I think, have had some mixed data on efficacy. I will say if all of the notifications are provider-facing only, I do think there's a chance of overload to clinicians as well. And this may be part of the reason why screening uptake has been suboptimal in this population if providers have not been willing to take on all of the onus with respect to screening. But this is something that could be explored further. I think right now our idea to randomize at the patient level was still to empower patients, connect them still with their primary care provider if they have one, and ensure that the usual channels of cancer screening are still available to patients as well.
Thanks.
Perfect. Thanks, Sabrina. Did anybody else from the audience or any of our panelists have any additional feedback or questions? Eric, I see your hand is up. You can go ahead.
Yeah, thanks. The idea of sort of nesting your trial in the center with EPIC, I think, is an excellent one with the patient messaging aspect available there. Assuming the trial is successful, how would you see generalizing that approach to other centers that may not have the EPIC system? So how would this sort of be translated into the real world, and would you see that as a barrier to knowledge translation?
So thanks for this question as well, Eric. We were worried initially as to what would be the best route to communicating with patients, and initially we had not envisioned doing all of this through the Epic patient portal, we had actually wondered whether it may be possible to make use of Trillium Gift of Life's contact information for transplant recipients as an initial way to reach them. We were initially under the impression there may have been existing and updated registry on the Trillium Gift of Life side. We did have some initial communication with them as patients during the pandemic were being notified by Trillium Gift of Life about vaccination options, but we've heard subsequent to this that there may not be sort of an up-to-date means of communication through TGLN. So for this reason, we sort of moved towards electronic health record and Epic specifically. My hope is that if this is of value, eventually other electronic health records may incorporate versions of patient portals that we could apply this type of intervention to. The other consideration is if it cannot be done through patient portal means, do we revert back to physically mailed reminders, which would differ still from the Ontario provincial screening program reminders in the sense that they're still tailored to transplant recipients and sort of have the imprimatur of the transplant program to indicate that this is, specifically that something the transplant program is looking to increase for patients. So my hope is there still may be an additional option to reach patients with this type of reminder notification, but I do think it is a barrier potentially for generalizability right now.
Perfect. Thanks, Eric. And Amit, we'll go to you next.
Yeah, thanks so much, Abby. Maybe you just want to give your thoughts on the outcome. At the end of the day, it's a surrogate endpoint. It's like adherence to recommended cancer screening. It's not actually reducing cancer mortality. It's a lot of heavy lifting to get adherence to this more adherence to screening, and yet at the end of the day, it's one step removed in terms of really impacting how someone feels, functions, or survives. So what are your thoughts in that space? Because it's a lot of heavy lifting you're doing for a surrogate endpoint.
Yeah, I think even in the discussion thus far, there have been a number of issues that still require additional work to explore. And, a question it's fair to ask, is all of this sort of effort worthwhile for a sort of process of care outcome? I do think the data we've seen with respect to screening uptake shows us that there is a care gap here that may lend itself towards relatively simple still intervention, but I guess this remains to be seen. Were there in existence another intervention that we could apply to improve cancer outcomes specifically in this population? Certainly we would consider other sort of pragmatic interventions to try and explore this, but I think we are sort of limited in terms of what is easily applied to this population, what can be done sort of realistically, and where there is an existing care gap. So my hope is that we will see that some upfront work without a lot of difficulty down the line in terms of sustaining the intervention will still provide a meaningful benefit to patients, both with respect to the uptake of screening procedures and maybe down the line if we had sufficient data and long-term follow-up to suggest a benefit with respect to cancer outcomes and patient satisfaction. Welcome additional thoughts from the group on this issue.
It is recommended care, so you're just trying to support recommended care, speaking from the other side of my mouth. So that makes a lot of sense. Thanks, Abby.
Perfect. And Monica, let's go to you next.
Thanks. So just to comment on the last kind of discussion, I do think it's a reasonable sort of intermediate outcome because that's what's been used in some of the studies. But then if you follow up from a long-term perspective, you might get the data eventually, whether it's impacted mortality, but it will take quite some time, right, to get that results on that outcome. So my question just actually goes back to the generalizability piece. I think you mentioned like what proportion of patients are being followed through the transplant programs versus primary care or like other means? And are those patients different than the patients that are the patients that are being followed in those programs different than the patients with kidney transplant who are not? And, what might that mean? Like, in what way are they different? Like, for example, is it, based, for example, on some sort of socioeconomic factors and sometimes a quality improvement intervention, if you don't think about these things ahead of time, might actually worsen outcomes for some of our most disadvantaged populations. So I have no sense of this, but you probably know about how representative are the patients in the programs.
Thanks for that additional input and question, Monica. I'd say still it's the majority of patients who are followed directly by the transplant program, even if it's very stable patients who receive less frequent or annual follow-up, something along these lines. I wish I could give you a definitive percentage in terms of the exact proportion, but still it's the majority of individuals. I would say those who are less likely to follow up with the program may be those who are further out from their transplant and have stability with respect to transplant function and immunosuppression. So that may introduce a difference with respect to the type of patient who is not followed by the program. Also, logistically, patients who are in areas more distant from their transplant program may be less likely to follow up directly. There are transplant recipients who may follow up sometimes with nephrologists who are not part of the original transplant program where patients receive their kidney transplant. Still, I'd say those individuals who are followed by nephrologists in the community would be those who meet those criteria of stability with respect to their transplant function and immunosuppression. So we would have to be careful that we are not introducing inequity with respect to the intervention in terms of a lack of access to receipt of reminders surrounding screening for these patients. One consideration is if the intervention was beneficial in the transplant program itself, could the eligible patients post-transplant be identified through other healthcare administrative data means, not necessarily through the transplant program, but through ICS, core other data sets that show transplant receipts? Then we run into the issue of how to notify them again, but this is something that could be explored if the intervention were found to be beneficial.
Perfect. Thanks, Monica. And Manuela, let's go to you next.
Thank you. So my question is still related to patients, and it goes along with Monica's comments. So it is how you will ensure the minorities are included in your analysis because of patients that are being followed by primary care practitioners will not be included at this stage. For some of the diseases, usually the minorities have lack of access to information and intervention. So how you plan to try to adjust this to this population? And how do you see the impact of more screenings in the Ontario healthcare centers? As well, how do you think the system and patients will manage the detection of false positives if they ever occur?
So thanks, Manuela. I would say the question around access for patients who are in minority groups is an important one. And I'm aware that the provincial cancer screening programs have looked to ways to, look at other language preference, other routes of communication for these individuals. I think for an initial sort of look at an intervention like this, we may be limited in terms of how broadly we can use this intervention to reach all minority groups. I will say kidney disease itself is a condition that disproportionately affects individuals who are in the minority, and patients who may have less health literacy may be particularly disadvantaged with respect to completing cancer screening. So I hope this type of intervention would still allow for benefit in these minority or disadvantaged populations. But I think initially we may need to keep our intervention as broadly applicable as it can be, and then look at reaching maybe minority recipients further down the line. Regarding the potential impact to the system with respect to increased cancer screening, I do think it's fair to consider. I would say because the overall proportion of transplant recipients in the province of Ontario is a relatively small number compared to the overall recommendation for population level screening for all of these malignancies. Like, you know, there are millions of patients potentially who are eligible for these screening interventions, whereas the transplant population represents, you know, a number in the few thousands of individuals. The capacity for additional screening should be available, in the sense that, you know, we should be looking to increase screening rates relative to this small number of transplant recipients in the province. So I don't think this should exceed capacity. Regarding the potential for false positive testing, I do think this is potentially a concern in this population as well. And for that reason, we want to ensure that this is a secondary outcome that's looked at and also particularly focused on when considering patients' perception of the screening intervention. I do think, you know, this is a recognized concern around screening and is still guideline recommended. So we wouldn't alter the screening protocol to try and mitigate the potential for false positives, but we do need to acknowledge this and monitor it as a secondary outcome. Thanks.
Perfect. So we are officially at the time where we're going to have to wrap up our Q&A. If we didn't get to your question, or if you have additional questions, please feel free to drop them in the chat and we'll pass everything along to Abby as well. And on that same note, this concludes our first session. So huge thank you and round of applause to Abby, our panelists, and all of you as audience members as well. That was fantastic. We're going to break for lunch now and return at 1 p.m. Eastern Standard Time. And from there, we'll go on to our next presentation. The session links are available in the session tab on the left-hand menu in the feed loop. And yeah, everyone, please go ahead and enjoy your break, and then we will see you soon.